So we proceed with non-biopsy, and it's a video as well by Dr. Amir Lebastchi from California.
Hi, good morning. Thank you very much again to the organizers for allowing me to give this talk today. It was a great meeting. I'm still here at the meeting, but I'm seeing that the program is running behind, and because I decided to record my talk. So the topic is post-ablation surveillance biopsy. I take the counterpoint, no. So I have a couple disclosures. I have another disclosure. I routinely perform prostate biopsies after my prostate ablations. I do systematic and targeted biopsies from the ablation zone. But I'm thinking, is it really necessary to perform prostate biopsies? The reason I perform prostate biopsy is because I was the first author on this Delphi consensus looking into surveillance methodologies after ablation. At that meeting, the Delphi consensus was to perform a systematic and targeted biopsy after prostate ablation. The recommendation was to perform the ablation between 6 months and 12 months after the ablation, and to perform a systematic and targeted biopsy. So that's why in my practice, patients get routine prostate biopsies after ablation. But is it really necessary? There are important considerations. Number one, do we do biopsies who undergo radiation therapy for prostate cancer? Number two, do we perform biopsies on patients who undergo ablation of tumors in other organs like kidney? Do we have inferior imaging in prostate cancer that it makes it necessary to perform prostate biopsies after ablation? Or number four, is prostate cancer more lethal than other cancers? Number five, do we have a biomarker to follow treatment success after ablation? So I want to go point by point and make an argument why biopsies may not be even necessary. Do we perform biopsies on patients who undergo radiation? No, the ASTRO came with the consensus statement in the Journal of Clinical Oncology, even back in 1999. The ASTRO panel judged that prostate rebiopsy is not necessary as standard follow-up care, and that the absence of a rising PSA level after radiation therapy is the most rigorous endpoint of total tumor eradication. So our colleagues from radiation oncology don't perform routine prostate biopsy after radiation. And as you guys all know, they perform radiation on way more aggressive cancers, on Gleason's 8s, 9s, and 10s, and they still don't perform prostate biopsies. Next question, do we biopsy patients who undergo renal tumor ablations? No, and this was just recently again published in the Surveillance Post-Radiofrequency Ablation of Small Renal Masses, Recurrence and Follow-up in the Canadian Journal. And they basically mentioned the guidelines after renal ablation. Recurrence was defined as any sign of new or residual tumor at any point during follow-up with imaging on either CT or MRI, anywhere in the originally ablated kidney. So in kidney cancers, we follow patients with CTs and MRIs after ablation. Well, but maybe it is because we have inferior imaging. Do we not have good imaging to detect prostate cancer? Well, as you all know, we have superior imaging for prostate cancer. We have prostate MRIs, which have even a very well-validated PIRATS classification. And in fact, the PIRATS classification gives us a risk prediction per PIRATS category, how likely it is that we have clinically significant prostate cancer. So we have excellent already imaging with MRI. And on top of that, more recently, we use PSMA PET scans. There we have a radioactive tracer to detect specifically prostate cancer with a positive predictive value in the ranges between 84 or more recently in the 97% range. So we have excellent imaging, probably better imaging than any other cancer in the body. But maybe is prostate cancer a more lethal cancer? And as you all know, this is from the American Cancer Society website, the prostate cancer 5-year relative survival rate for localized and even for regional cancer is over 99%. Just head to head on the right side, the kidney cancer. The 5-year relative survival rate is 93% for localized and 74% for regional cancer. So in other words, prostate cancer has superior survival rates to other cancers that we ablate and don't biopsy. The next question, do we have a biomarker to follow treatment success? Well, as you all know, going back again to our colleagues from radiation oncology, they mentioned that PSA is an excellent marker to evaluate success. Again, they mentioned a rising PSA level after radiation therapy is the most rigorous endpoint of total tumor eradication. So as opposed to other organs, in prostate cancer, we have actually a biomarker to follow patients with prostate cancer and to see if the treatment success. And we can just follow and act if the PSA goes up and perform biopsy. We should probably not perform routine prostate biopsies. And this society, the Focal Therapy Society, when we performed the Delphi consensus, we also concluded that PSA is an excellent marker to evaluate success. The statement of the panel was, a serum PSA was accepted as the preferred non-imaging biomarker in the follow-up and should be included in post-procedural surveillance. A PSA drop of over 50% was a good indicator for treatment success. So in conclusion, we don't biopsy patients who undergo radiation for more aggressive prostate cancers. Gleason grade groups 4 and grade groups 5, Gleason 8s and 9s and 10s get radiated, and we don't perform routine prostate biopsies. Next point, we don't biopsy patients who undergo ablation of more aggressive tumors, including kidney and liver. We just follow with imaging after those ablations. Another point, we have superior imaging in prostate cancer. We have excellent prostate MRIs, and more recently added a PSMA PET scan to our armamentarium. So we have excellent imaging for prostate cancer. The next point, prostate cancer has a more favorable mortality rate compared to other cancers that we ablate. So why are we still performing biopsies for prostate cancer if we don't perform them for kidney and liver cancers? And finally, as opposed to kidney and liver cancers, we have actually a good biomarker to follow patients, follow treatment success. So I think there's enough evidence that we should reconsider if routine prostate biopsies are still necessary after prostate ablations. Again, I perform it right now because it's part of the Delphi consensus, but is it really necessary to perform routine prostate biopsies? I think no. Thank you very much.